Good morning, everyone. We're going to give it just a minute or so, let a few people hop on before we get started. Dawn, good morning. Good to see you. Good morning. Hello. All right. All right. Well, it looks like we got a good chunk of people, so let's go ahead and get started. So thank you so much, everyone, for joining us today, and welcome to part one of our three-part brain injury training series. I'm Hannah Nixon, Director of Marketing here at TCare, and I'm so excited to see all of you, and lots of good chat already going today, so that's exciting. Hopefully a lot of engagement. We're especially excited to have Jill Farrington and Judy Detmer with us today from the National Association of State Head Injury Administrators. They both bring so much knowledge and experience into the brain injury space, so we're super grateful to have them throughout this series with us. Um, Feel free to put any comments or questions in the chat, and we'll try to answer them as we go. This first session is pretty straightforward, so I'm going to go ahead and pass things over to Jill and Judy so they can dive right in. So Jill, Judy, take it away.
Hi there, welcome to our session today. I'm Jill Farrington. I'm with the National Association of State Head Injury Administrators. I am our Director of Community Integration at NASHA, and I'd like to ask my colleague Judy to introduce herself.
Good morning, everyone. I'm Judy Detmer, and I am Director for Technical Assistance and Special Projects at NASHA. Great to be here with you all.
All right, we have just a little bit of your morning today, depending on where you're coming to us from. I think everybody should probably be in the morning hours. And we would love to get a better feel for your participation, your roles as caregivers, or as we understand it, some of you are care managers. So if in the chat you might put the items that are on the slide, your name, your state, we think that would be really interesting. Just in one word, who you care for, an older adult, an adult, a youth, or a child, and then what you're hoping to get out of today's session. And of course, if you are not technically a caregiver, feel free to skip the third item. But if you could spend just a moment putting that information into the chat, we would be very interested to see the representation today. Thank you. I see lots of notes coming in. Michigan, Florida. All right. I will go ahead and move us on to the next slide. I mentioned that Judy and I are from NASHA, and our organization is created to assist state governments and their partners to improve systems so that people with brain injury have improved quality of life. TCare focuses very strongly on improving the lives of caregivers. So we know that our work overlaps significantly, and that brain injury is something that some of you may know that is a factor for a loved one or somebody that you have on your care caseload. It also may be the case that you're working with someone or have a family member that has more of a hidden brain injury. So we want to bring this topic to you all today. We really feel like our organizations have a close alignment with our commitment to improving lives, and that's why we're doing this session today. At NASHA, we do a variety of activities. We develop resources and information. We invite you to go to our website, join our newsletter. You'll find an abundance of resources at the NASHA site. Training and professional development, such as what we're doing today. We offer workshops. Just a couple weeks ago, we had our major annual conference at which TCare was a guest, speaker, exhibitor. We were very excited for that. We work to bring state agencies and their partners together where they're not already established as partners. So to look at opportunities to strengthen the infrastructure and the capacity for people with brain injury. We stay on top of state and national trends, and we're very involved with advocacy to assure that systems and supports for brain injury not only stay sound and current, but that they expand. Today, what we wanted to do is to build some awareness about brain injury in older adults and also just generally people with disabilities of all ages, teach some recognition of signs and symptoms, provide some practical strategies for common challenges for you, and empower you as caregivers or care managers to know when you might want to seek future help. And then to give you some ideas and resources about what that might look like. Why brain injury really matters in caregiving is multifaceted. When we understand the condition, when we learn to recognize it, it can solve questions or concerns that we may be experiencing either in our families or with a person that we're serving. We can learn from our study of brain injury when conditions may just be temporary and that what we're seeing may be short-lived, or when to understand that there may be concerns or limitations that might have more of an ongoing chronic nature. We think that when we learn about brain injury, what is really great is that we fill up our toolbox with some strategies to better interact with and support people with brain injury. And then finally, we get to better understand the resources that are out there. When it might feel like there's very little, there actually in many states are some robust services, and we'll be talking about that a little bit today. So with that, I'm going to turn it over to my colleague, Judy.
Great, thank you, Jill. So this is going to be kind of brain injury by rapid fire, by fire hose. So if anybody has questions or wants a follow-up, please let us know. We can either provide some of that support or connect you to your local resources too. So just to give you kind of that really broad basic overview of brain injury, I thought we could start with kind of what the definition is. A lot of people have heard the term traumatic brain injury, which is an external force or blow to the head, and that typically results from assaults, falls, blast injuries, motor vehicle accidents, those kinds of events, but it's an external blow. Less commonly understood is non-traumatic brain injury. And really what we see is that acquired brain injury is the umbrella term encompassing both traumatic and non-traumatic causes of brain injury. Non-traumatic brain injury can be caused by an internal event, such as a stroke, a tumor, or lack of oxygen to the brain, or an infection. And so as we go through the session today, just kind of be thinking of who you're taking care of or people you know, and if this fits for them. Just don't only think about those with external blows as brain injury. Both can really benefit from strategies. Next slide. So when we think about prevalence, just wanted to give you some sense of kind of the overall prevalence of brain injury, because I think this is also misunderstood since you can't really see brain injury often. Oftentimes people will not have an outward appearance of having a brain injury. It's more behavioral consequences that you can observe, but oftentimes that doesn't get tied back to brain injury. And so really, with some national surveys that have been conducted, around 20 to 30% of the general adult population would self-report that they've had a concussion or a brain injury. And just a quick word on concussion. I say concussion or a brain injury, but concussion actually is a brain injury. Typically, though, if someone's had one concussion, uncomplicated concussion, they'll resolve back to their baseline. But it's when we see people having multiple concussions that can lead then to chronic and prolonged symptoms of brain injury. So these numbers may seem high to you, but when you think about the full range of those who have a concussion and resolve to those who have long-term consequences, is pretty accurate. That's for adults. And about 10% of children will endorse having a brain injury. Particularly of note is that around 75%, or sorry, around for people age 75 or older, that's where we see the highest numbers of brain injury, hospitalization, and death. So we'll talk a little bit more about some management techniques, but that is a population to particularly pay attention to. And I would say on the flip side, when we think of younger ages, 1 to 4 tends to be a high prevalence rate of brain injury. And sadly, that often is related to abuse. And so again, may go unreported. And when we think about older adults with brain injury, it can get complicated because there could be co-occurring age-related dementia or other activities going on, or it could just be confused for those kind of age-related conditions. Males are about 2 times more likely to sustain a brain injury with loss of consciousness than females are. And then it's estimated that 1 in 4 adults will fall annually. So falls nationally are the #1 cause of brain injury. And so that's again why we think about our aging population, the rates of falls that they experience, and then co-occurring brain injury. Next slide. So I mentioned this already, but if you think about common causes of brain injury, that's where we're seeing falls being the most common. Accidents such as car accidents, bike accidents, getting hit by being a pedestrian, getting hit by a car, those kind of things. And then stroke is a very high common cause when we think about non-traumatic brain injury. And then unfortunately, assault is also a pretty high cause or rate of brain injury as a result of assault. The other thing that we see in terms of risk factor, age is a risk factor for outcomes, poor outcomes related to brain injury. It's just as we age, we are not able to recover as easily as when we're younger. And so we see that the impact of brain injury can be worse for those who are older. And then they have comorbidities that make it more challenging as well. And along the lines of having co-occurring conditions, we also know that medication use can cause brain injury, but also make recovery from brain injury more challenging. And when I say cause brain injury, it's because it can lead to an increase of falls and other activities. And then when we work with people with brain injury, we often see a strong co-occurrence with substance use and brain injury. And again, it's that chicken or egg kind of thing. The substance use can cause brain injury because people take greater risks when using substance or not as steady. And sometimes brain injury can lead people to using substances in an unhealthy way to help cope with the brain injury. Next slide. So you all will be, as you're working with people, some of the things to kind of keep in mind that you can observe as it relates to brain injury. When we think about those signs and symptoms, we put them in the physical, cognitive, and emotional buckets. And so when we talk about physical, you may see an increase of headaches. This is often immediately after a concussion or brain injury, but it can also persist long term. Same with dizziness. Oftentimes people after brain injury will have vestibular issues, can cause dizziness or balance issues. Sometimes it's the motor part of the brain was affected, so balance can become an issue, or gait and walking can be challenged based on the brain injury. So those are some of the physical symptoms to kind of keep an eye out for. Cognitive, we see greater confusion and a change. And so I think this is something to kind of stress. As you are supporting someone or giving care to someone, typically you'll see a change. And so they're behaving in one way, and then all of a sudden it's like, what's happening? All of a sudden they seem more confused, their memory seems worse, their judgment seems off. Those are things that can result from a concussion or a brain injury. And then when we talk about the emotional piece, we see greater irritability. Oftentimes depression and anxiety can follow brain injury, and we see mood swings more often. Next slide. As I went through those, I'm sure you're all kind of thinking, this is typical for a lot of things. So we do see that. And I think that's why I kind of stress to look for a change is a big piece to this. And also, there has to be actually an incident, a brain injury. So if you see these things, asking questions like, did you fall? Did you hit your head? Those kind of things will be important. So when we get into kind of care strategies, we can break this down in a few different ways. One, we can think about prevention and brain injury. And that, when we think of elderly or aging population, prevention is a key. So having your homes well lit, making sure that rugs are tacked down or getting rid of rugs that slip, because again, falls are that number one cause. And so if we can take care of our environment to help prevent falls, we're going to be helping someone maybe prevent a brain injury. If someone does develop a brain injury, has a concussion or brain injury, then some things to think about for communication tips, just being very clear in your communication, slowing down your pace. Speed of processing can be affected, so their ability to take in what you're saying and understand what you're saying can be delayed. And sometimes that can look like they're confused or not paying attention when really they're trying to understand it and make sense of it. So just being clear, concise, keeping your pace a little slower, being calm, and repeating instructions, making sure that they understood your instructions. So you can say it and say, this is what I need you to do, and then have them say it back to you and demonstrate that they understood. Structures and routine are really important. And I know that's true also for disability generally, and also for people who are aging. But for sure, for people with brain injury, if you put into place good structures and routine, you help to mitigate the issues around memory loss that can occur with brain injury. And just that cognitive drain, having to think about what's next. It becomes automatic for them. So thinking about pacing activities and building in rest, I will say that fatigue and brain injury go hand in hand. And it doesn't matter how severe the brain injury, it's something people with brain injury always experience. And so being mindful and watching if someone's getting agitated or feeling like they're dragging, make sure to just take a rest. You can't push through that. You just need to take a break. Okay, next slide. I wanted to talk about can't versus won't. And this is our little friend, the T-Rex, trying to hang some curtains. And you can kind of get a sense of there's no way he's going to get those curtains all the way up where they need to be. Physically, he can't. With brain injury, we often misunderstand when people don't behave in a way we want them to or perform in a way we want to, that it's willful behavior, that it's something that they're intentionally doing. But it's really important to take a step back and think, do they have the skills in the first place to actually be able to do what we're asking them to do? And if they don't, that's where we start to work on strategies to build those skills. And when we think about those types of things, it's what we call compensatory strategies. So if I have short-term memory loss, then one strategy you could use with me is to tell me to write it down, or write it down for me if I have difficulties writing. Help me put it in my calendar, help me set up notifications, medication notifications, those kind of things. Again, some of the things we talked about with comprehension, make sure I understand, make sure you have my attention before you give me instructions. So we like to highlight this because unfortunately, a lot of people with brain injury get labeled as having a behavior problem, when in fact, it's really a skill deficit where they need to be taught how to actually perform the skill. Next slide. So when to seek further assistance can also be broken down into a couple of areas. One is more immediate acute support. So if someone has actively sustained a concussion, what you want to watch for with that is just monitor. I mean, it's always best practice, honestly, to take people to see a doctor, but you can just monitor for worsening confusion or headaches. Symptoms should decrease versus increase. If you see an increase of symptoms after a fall or a concussion, that means there could be an internal issue going on, such as a bleed or a hematoma, and those require immediate care. So I just say, in terms of being safe versus sorry, take them to a doctor, let them know that the person fell, get them checked out. and same with like changes in behavior. And I know oftentimes having cared for aging parents and relatives, oftentimes they don't want to admit that they fell, because that means that, maybe you're going to have to put in greater levels of care. And so they may not tell you this, right? Obviously, you guys know this, but so then we watch for these kind of things, sudden changes in behavior. Like, is something going on here? If someone loses consciousness, even briefly, or they just seem confused or dazed, that again is a time I think to seek care immediately. On the longer term, people with brain injury, what we're finding is brain injury is a chronic condition, and it ebbs and it flows in terms of the effects. And so we used to think you had a brain injury. These are the deficits you experience. This will be the rest of your life with these deficits. What we see is as people age with brain injury, we see symptoms worsening just because of aging and other symptoms coming on or other conditions coming on. So watch for any kind of decline in ability to care for self where before they had that ability. And then that's when you can seek further assistance. Next slide. So we wanted to leave you with some good resources because, again, this is very brief. So some of the information here, you'll see caregiver information. The Brain Injury Association of America is a very good resource generally. If you go to their website, you'll find all kinds of things there that might be informative for you. But this Caregiver Information Center will be particularly helpful. The other piece that will be helpful is to know kind of your local resources. And most states have what's called a Brain Injury Association or an advocacy organization. And if you go to the link that's in the chat here, you'll go to a map and see where your local association is. Same with us at NASHA. We have a state directory of both brain injury associations, but also state agency services that might be of support. So you can always check out our directory. And then again, for general information, the Model Systems Knowledge Translation Center is an excellent source, and we linked you to some fact sheets that are written for caregivers or people with brain injury if you want to do some further education and informing yourself on this topic more. There are some Spanish-specific resources, and this is one, support resources specifically in Spanish. So if that's a population that you're supporting or a family member that you're supporting, that could be a really good resource for you. And then finally, at NASHA through Technical Assistance Center, we produce this aging guide, and it's kind of giving guidance about how to support people aging with a brain injury. So hopefully those will be some good resources for you. But I think at this time we want to open it up to questions and make sure we can have a time to answer your questions. And Ruth, I see your question. I don't know about French, honestly, but I think if you go to the Model Systems Knowledge Translation Center, you might be able to find some resources that are in French. They've got multiple languages. Any other questions, or feel free to go ahead and put them in the chat or in the Q&A, whatever is most comfortable for you.
Some of you may be attending the second of the 3-part series tomorrow. What you'll find if you come tomorrow as a care manager, it's a little bit more extensive, deeper dive around these brain injury topics, going a little bit more into trying to pinpoint potential brain injury when it may have occurred. So we absolutely look forward to seeing some of you again tomorrow, and know that this is a very high level session today. Tomorrow will be some more extensive, and we very much would love to answer questions that you have. Looks like, have you seen brain injuries with individuals with ADHD and autism?
I'll jump into that, Jill, and please add anything you would like. Yes, we definitely see that co-occurring with autism, developmental disability, and ADHD. I think so. One of the things that we struggle with a little bit is to think about how important is it to understand brain injury, or if it's ADHD, or if it's autism. It is important because understanding if they have a brain injury may just give you more clarity to why they're struggling, in addition to the other disability or condition that they have. but it's not as important when we think about just identifying what challenges they're having and being sure to address the challenge. I think that can be true for any disability, honestly, is to say, okay, if they're struggling with short-term memory, what can we do to give them compensatory strategies? Or if they're struggling with organizational skills, how are we going to help them compensate and teach them skills to do that? So, but there is a strong co-occurrence for sure. Thanks, Susie. I see that you put something in in your remark about Kansas having those individuals seeking the waiver, brain injury waiver.
And I would just add that when we think about people that have intellectual and developmental disabilities, we know that there is a higher risk of falls. And so we want to attend to that increased rate of brain injury for people with intellectual and developmental disabilities, which is where, certainly some people with autism may be served under that system. So there is a higher risk of falls there as well. And Susan mentioned for those who have acquired skills but have lost them due to a brain injury, we want them to have resources to help them with their unique rehabilitation. Thank you very much, Susan from Kansas. We are happy that you're here. Just yet, I'm not seeing additional. Oh, I see now we've got how often should a person that has, sorry, that question fell off. Let's go with,
Have
go
brain
ahead, Judy.
injury follow-up worker appointments. Oh, so basically I think the question is how often should you have follow-up appointments? I'm hoping that's correct. Okay, yes. Well, I would just say it depends on what we're talking about here. If the person has an acute brain injury, it's going to depend on how they're recovering. What we find with concussion is that it takes oftentimes stroke, I see. Concussion's about four weeks or so before you're going to see someone fully resolving, and they may not ever fully resolve. So it's important to just monitor closely. With stroke, that immediate care is the most important. The immediate intervention is most important. So I would definitely be saying, I mean, I don't know, I'm not a doctor, but I would be following up weekly, if possible, with someone who's had a stroke, just to get them the right supports and information that they need to do well with having had a stroke. And again, over time, that's going to lessen because they're going to become static. It's going to be, they're going to reach a plateau of healing recovery, so that you can slow down some of those interventions.
We also have a question over in the Q&A, Judy, which is, what is a good medical test for TBI?
That's a good question. Truly, if someone, again, it's the difference between acute versus you've now recognized someone may have had a brain injury. The gold standard for really assessing brain injury past that medical piece is a neuropsychological evaluation. The issue around neuropsych eval, so that's objective measures to give you an idea of how somebody is functioning across kind of those domains we know to be really true to brain injury, like I've been mentioning, memory, organization, problem solving, reasoning, some of those things. It'll give you a good picture of if brain injury is part of the picture of what they're struggling with. I will just put out there the caveat that getting a full-blown neuropsych eval can be pretty challenging. It's expensive. You have to have a good advocate to get insurance to pay for it, but it can be done. And if you're working with someone who is aging and dealing with brain injury, so there may be complications of co-occurring dementia or brain injury, a neuropsych is definitely what I would advocate for, a neuropsych evaluation. If it's somebody who doesn't have those kind of complications going on, a neuropsychological screen, much more condensed, a couple of hours, can still be very beneficial. Or a psychological evaluation, just a general psych eval, where you're asking questions like, how are they functioning with memory, problem solving skills, judgment, those kind of things. So it tends to lean less medical, more on those psychological tests at that point. For acute brain injury, a concussion, we're looking at balance, vestibular issues, any kind of bleed, that's going to require a CT. So it's kind of different approaches depending, and happy to chat more about that if you need.
Terrific. I think we'll turn it back over to you, Hannah, as we've reached the bottom of the half hour in the various time zones of our attendees. And we're just so appreciative to have been here today. Thank you.
Yeah, awesome. Well, thank you all so much for joining us today, and a big, big thank you to Jill and Judy for kicking this off for us. So just a reminder, this is part 1 of our series, and we have part 2 tomorrow, and there is a link in the chat for you to sign up for that. If there are no other questions or any comments or anything like that, we'll go ahead and close it out. So thank you all and have a great day. We'll see you tomorrow.
Thanks, everyone.
Thanks, everyone.